Welcome, this is Jason Williams, and today we're going to discuss central line troubleshooting and risk reduction strategies. So when comparing the three major veins for cannulation, they all have a similar complication rate according to the 3 Sites trial published in 2016 in the New England Journal of Medicine. It was a trade-off in terms of what complications you saw. So subclavian had a major rate of pneumothorax requiring chest tubes, femoral access had a high rate of DVTs, and then jugular vein has a mix of those two complications. So the conclusion from this trial is essentially choose the easiest target of the three, and you're likely to reduce mechanical complications. And then take out the catheter as soon as possible, and you're likely to reduce DVTs and bloodstream infections. So how do we choose an easy target? First, consider the size and the depth of the vein. So this would be a nice big jugular vein compared to the carotid, and very superficial and close to the skin. Versus a tiny jugular vein that's very deep, it's going to be hard, and you're more likely to get arterial puncture or pneumothorax if you're digging around trying to hit a difficult target. And always ask yourself, how close is this vein to the artery or lung? And if I miss and go through and through, am I going to end up right into the artery or lung potentially? And if the right jugular vein doesn't look good, then check the left side. And then increase the Trendelenburg of the patient, which will push more blood into the neck veins and dilate them and potentially give you a bigger target to shoot for. And if that still doesn't help, check the bilateral femoral veins and be sure to ultrasound the crease of the thigh, which tends to make the femoral vein the largest and most medial to the artery. Another very common complication is pain. Be sure to use the small 25 gauge needle and use a ton of lidocaine. You guys are very good at placing a wheel as seen here, but don't forget to also anesthetize the actual track that your introducer needle will pass a little bit deeper and closer to the vein. And you have 5 cc's of lidocaine, so feel free to use it all during this phase. It's important as that dilator is going through, it causes a lot of pain and discomfort, tearing sternocleidomastoid, tearing subcutaneous tissue. So the more lidocaine you can get in the path of the dilator, the more comfortable the patient will be. Very common scenario is difficulty advancing the guide wire. So if you're feeling resistance while pushing the guide wire, ask yourself, am I getting resistance very early on at less than 10 centimeters? And if so, the problem's the wire. As it emerges from the tip of the needle, it's hitting something. Or if you're getting resistance after 10 centimeters, the wire's clearly left the needle and is likely in the vein, but you're hitting some distal obstruction. And this will help you sort out the potential differential. Don't forget to keep track of your hash marks on the wire. The first hash mark is 10 centimeters, 2 hash marks is 20, 3 hash marks are 30 centimeters, and keep track of these and they'll help you figure out what's going on. So here's the scenario when you're hitting resistance at less than 10 centimeters. It's just as the wire is exiting the needle tip. In the best case scenarios, as the wire exits, it's hitting the back wall of the vein, and it just needs to bend a little bit to continue advancing. So a little bit of increased resistance is totally normal as this wire bends and starts to advance down the vein. So you have to ask yourself, as I push, is the wire advancing, or is the wire bouncing back at me? And if the wire is bouncing back at you, it's very likely your needle has left the vein and has either been pushed out the back wall or your needle's been pulled out of the vein and it's poking the subcutaneous tissue and not able to advance whatsoever. If the patient ever says ouch or is having pain or discomfort during the wire advancement, that's usually an indication that you're poking them in the subcutaneous tissue with the wire. So retract your wire, reattach your syringe, and try to aspirate blood. If you can't aspirate blood, then you're not in the vein any longer. And then pick up your ultrasound and find your needle tip and place it back into the vein. So how do you prevent this? So first of all, put your needle tip in the middle of the vein with your ultrasound. A lot of people, as soon as they start aspirating blood, they throw down their ultrasound and start moving. But if you take an extra second before you put down your ultrasound and guide your tip of the needle right into the middle of the vein, that'll give you maximum flexibility. In case your needle tip is moving, you're less likely to pull it out of the vein. And finally, really focus on the needle when you do put down your ultrasound, remove your syringe, and insert the wire. Stare at that needle as much as possible and try to minimize movement, and that'll keep the needle tip in the vein. We talked about how to manage and troubleshoot if you're getting resistance at less than 10 centimeters. If there's resistance at greater than 10 centimeters, again, your wire is in the vein, and it may be taking the wrong turn down the subclavian, or you may be hitting a DVT or a venous stenosis. So to troubleshoot this scenario, one of the things you can do is actually pick up your ultrasound again and follow the wire down to the clavicle and see if it's taking a wrong turn towards the subclavian or towards the patient's shoulder as opposed to taking the correct turn medially. If you think you're coming down the subclavian, you can take out the needle and thread the angiocath, the small 18 gauge IV, over the wire, and then you can retract the wire and try to turn the J-tip and redirect it medially. This may cause the wire to bend in a more medial direction as opposed to bending laterally and going down the subclavian. A very common scenario is inability to advance the dilator. There's a couple common reasons for this. One is because the skin nick was originally inadequate, and this is because people have been told for years now, don't cut the wire with the scalpel. And because everyone is very afraid of touching the scalpel to the wire, they end up leaving a little tag of skin between their skin nick and their dilator. And this is ineffective. You've essentially not opened up the skin or given yourself the ability to advance the dilator in this scenario. Don't worry about your scalpel touching the wire. I've tried several times in a simulated scenario to cut the wire with the blade, and I've spent 20 minutes trying to hack it apart, and it's physically impossible to cut modern wires with the scalpel. So you actually need metal on metal during your skin nick in order to fully open up the skin nick to allow space for your dilator to advance through the skin. Another common scenario is as the dilator is advancing through the skin, if there's a lot of floppy skin or if really dense sub-Q tissue exists, as you push the dilator, the skin and sub-Q tissue slides this direction as well. That can cause a bend or a kink in your wire. So if you're getting a lot of movement of the skin and sub-Q tissue as you're advancing the dilator, have an assistant place their hand behind the dilator and give some counter traction. Pull back on the skin to prevent it from sliding this direction. That may give you better alignment as you're able to advance and push the dilator. And here's another common scenario where you spent your entire time with your needle at about a 45-degree angle getting your needle and wire into the vein, but then when you go to thread the dilator, people often keep it parallel to the skin. And this pressure is not going to dilate in a way that's heading towards your original skin puncture and venous cannulation. So you got to get your dilator up at the same angle and trajectory that your needle originally entered the vein. And all of these scenarios can result in a bend or a kink in your wire, and this can be pretty dangerous. So you got to be careful troubleshooting this. So the reason why this happens is as the dilator is being pushed in, people make the mistake of also pushing the wire in or letting it come in together. And if both the wire and dilator are entering the skin, it's going to cause a bend or a kink, and you'll get off trajectory. So to correct this scenario, stop pushing on the dilator and pull back on the wire. And as you pull back on the wire, it'll straighten out the wire, and if you have a bad kink, it'll pull it into the dilator, and now you can freely advance the dilator over the straightened out segment of wire. In fact, you should always maintain this tension on the wire and be pulling back on it gently as the dilator advances. The wire should truly be fixed this whole time. Other ways to prevent issues with the dilator is hold it like a pencil, very close to the skin, and give a gentle twisting with firm, steady pressure at small half-center increments as you twist and push, twist and push, twist and push. Always maintain constant tension on that guide wire so you don't cause a bend or a kink. Advance the dilator at the same angle to introduce your needle, and this will give you better leverage to advance. If you're really having trouble pushing that dilator in, just take a pause for a second, double check your skin nick. You can ask an assistant to hold some counter traction on the skin to prevent that sliding. And if you've been pushing and pushing the dilator for a couple minutes and you're having trouble, be sure to pause and pull back on the wire 2 to 3 centimeters. That may remove a kink or bend that you've created after struggling with the dilator. All right, here's a chest x-ray following a central line placement. This was supposed to be a right internal jugular vein cannulation, but the superior vena cava is down here, and the catheter crosses the midline and heads towards the aortic arch. So this is a carotid cannulation heading down towards the aorta. Your right internal jugular catheter should always stay on the right side and should never cross the midline. It should look like this. This is beautiful right IJ cannulation coming in to the superior vena cava, and it never crosses the spine. The opposite is true with the left internal jugular vein. This catheter should cross the midline and come into the superior vena cava. Unfortunately, it stays on this ipsilateral side and again enters the aortic arch and is now in the descending aorta. So left IJ should always cross the midline, right IJ should never cross the midline. Venous, arterial, arterial. So how to prevent arterial puncture? It's actually really common to have the needle encounter the artery. So if you're not following your needle tip with ultrasound, you can occasionally hit the artery. Or if the vein is very collapsible, it's easy to go through and out the back wall of the vein into the artery as well. So you want to recognize this as soon as possible. So when you remove your syringe, you don't want to see bright red pulsatile blood. You want to see dark, non-pulsatile venous blood. Arterial, venous. If you do see arterial blood, just pull out the needle and hold pressure for 5 to 10 minutes. You have one last final check that's really important to do. We've had several catheters end up in the carotids over the years, and every time that happens, they forgot to ultrasound the wire. So before you dilate the artery on accident, be sure to ultrasound and make sure the wire not only enters the vein, but continues sliding all the way down the neck towards the clavicle to make sure it doesn't come out the back wall into the carotid behind it. And then rotate your probe 90 degrees to view this in the long axis view and make sure your wire again is in the vein. This is the most common step forgotten when catheters end up in the carotid. If you're still not sure after these first two steps, you can always measure the central venous pressure. And to do this, in your kit, again, is a 6 centimeter 18 gauge angiocatheter. It's like a peripheral IV, but longer. Slide this peripheral IV over your wire, take out your wire, and grab the 2 feet of extension tubing in your kit, fill it with a little bit of saline, connect it, and if you have a patient with low central venous pressure, that saline column will fall right into the catheter. If you have arterial puncture, the blood will fill and rise up and up and up and usually squirt out the top of your IV tubing. This pressure is not the central venous pressure, this is an arterial cannulation. If the blood column does rise up a little bit and stops after 5 or 10 centimeters, that's probably central venous pressure. The patient's just volume overloaded due to CHF or renal failure. If the blood continues up the column and falls out the top of your tubing, that's for sure arterial puncture. And if you don't notice it and try to bolus somebody's saline, that blood will rise right up into your saline bag as well. Very rarely, if these 3 steps should almost always confirm venous puncture. Usually the first 2 are good 95% of the time, and very occasionally you can confirm with the pressure tubing. These last 2 steps aren't commonly done because they're labor intensive and just take too long, but theoretically you can connect the tubing to the actual monitor and look at the arterial or venous pressure tracings, or you can ask the respiratory therapist to send the blood for a blood gas analysis and look at the O2 saturation to differentiate arterial versus venous sticks. So you want to catch this prior to dilation, and if you just stick a needle, wire, or 18 gauge angiocath in an artery, just pull those small devices out and hold pressure for 5 or 10 minutes. Unfortunately, if you've missed it and you've ended up dilating and placing a catheter into the artery and torn a big hole in the artery, you do have to call vascular surgery prior to removal in case they need urgent vascular surgery repair of that big hole you've created. And you really want to get those out as soon as possible because these catheters will form clots in an artery which can then embolize to the brain. This is what you want to see for this is a subclavian, and again it crosses the midline and enters the superior vena cava. Unfortunately, there's a large pneumothorax that resulted from this CVC. So pneumothoraxes result if your needle puncture starts too close to the clavicle. So again, you should always stay at least 2 to 3 centimeters above the clavicle. The clavicle is really the gateway into the thoracic cavity. And always keep track of your needle and follow your needle tip. And one of the clues you can use as you're still learning to follow your needle tip is check on the depth of your needle. Occasionally take your eyes off the ultrasound screen and look down at your needle itself and ask yourself, how much of the needle have I pushed into the patient? Most jugular veins are only 1 to 2 centimeters deep. And so you have a 6 centimeter needle, and you should almost never hub a 6 centimeter needle in order just to go 1 to 2 centimeters. So if you look down and you've inserted half of your needle, you've missed the target and you should pull back out and reassess where you are. Always monitor the depth of your needle and in relation to how deep your vein is. People struggle to follow their needle tip because they're not sliding their ultrasound forward. And so what that ends up looking like is they have their ultrasound initially here, they make their skin puncture, and the needle just keeps getting deeper and deeper and deeper, and the operator thinks they're looking at the needle tip above the vein, but really you're looking at the shaft of the needle, and your needle tip gets much deeper than appreciated. That's why you should always aspirate as advancing, because in this case you should have aspirated blood as you first got in, and that would be your clue that you entered the vein. This person wasn't aspirating, continued through the vein, and now is approaching the lung apex. During advancement of the needle, you should be sliding your ultrasound constantly to actually track the true needle tip. And what that will look like is you find your needle tip way down here, much deeper than appreciated. Again, stay at least 2 to 3 centimeters above the clavicle when starting your needle puncture. And if you have a difficult jugular venous cannulation because the anatomy is difficult for whatever reason, don't hesitate to do a femoral central line placement. It's hard to cause a pneumothorax in the leg. If you do cause a pneumothorax, the central line can be left in place if it's functioning, and definitely don't attempt a central line on the contralateral lung. If they only have one good lung remaining, you really don't want to pop that one remaining good lung. Bleeding is common, and small hematomas are not infrequent, and commonly if you poke the vein a couple times and come in and out and have difficulty keeping the needle in, you'll get small hematomas as you've kind of turned the vein into Swiss cheese. But more serious bleeding can occur if you end up lacerating the vein or causing arterial injury. So one way to reduce the risk is correcting coagulopathies whenever possible. That includes trying to transfuse FFP or platelets to reach generally recommended goals, though it's not always possible in emergent scenarios. And always consider desmopressin or DDAVP to activate platelets that are inhibited by uremia. So if your BUN is ever greater than 60, you can really activate those platelets, make them stickier, and that may reduce bleeding in those scenarios. It only lasts for a short period of time, so you want to give the DDAVP as soon as you're starting the procedure because the effect will wear off after 60 minutes or so. So one of the things you want to be sure is we are always adjusting the needle tip. We're swinging it back and forth up here to approach the vein and get on a good trajectory. But if your needle tip gets really deep, you really don't want to swing across the vein and end up lacerating the top of it or the artery. So in this case, you really have to pull back into more superficial tissue, then change your angle, then re-advance. You should never hub the dilator. The dilator is meant to tear through subacute tissue and sternocleidomastoid muscle and to remain rigid and straight. And so if you continue to push, it's going to tear through the back wall of the vein just like it tore through all the other subacute tissue on top of it. So if your vein is only 1.5 centimeters deep, you should only insert 2 centimeters of your dilator. You should never hub the dilator because you could tear the back wall of the vein. And with femoral venous cannulation, just like we stay 2 to 3 centimeters away from the clavicle with IJ, with femoral vein, you should be avoiding the inguinal ligament. So again, the inguinal ligament connects the symphysis pubis to the as-is, and you want to stay below that because a tear in one of these arteries or veins will bleed into the peritoneum and cause non-compressible site of bleeding. You don't want to go too low though. You'd like to stay in the crease of the thigh, and this is where if you bend the patient's thigh, they'll have a nice crease as it intersects the groin, because this is where the vein will be nice and medial and large. So here's a nice large femoral vein compared to the two little arteries, and this is where you want to go. If you go much lower, the vein is going to dive below the artery. It's going to get much harder to cannulate. So shoot for the crease of the thigh is where you want to ultrasound. If you do cause bleeding, usually holding pressure for 5 to 10 minutes will correct it. And then often you'll have to select a different site for cannulation because the hematoma can obstruct your view of the vein. Arrhythmias are common, often occurs when the wires advance too far into the right atrium or right ventricle. So you always want to have your patient on cardiac monitor. You'd prefer to detect 8 beats of VTAC and then pull back your wire 3 to 5 centimeters, as opposed to detecting it after 2 minutes when people are coming in and doing chest compressions. It's hard to complete the central line in the middle of the code. You really shouldn't have to insert your wire more than 20 centimeters to try to keep it out of the heart. You only have a 20 centimeter long catheter, so there's no need to insert the wire more than that. Air embolism is rare, but we've certainly seen it before, so be sure you never have air in your syringes as you're flushing saline into the catheter. And try to minimize the times where the vein is open to the atmosphere, especially in hypovolemic patients. It's those collapsible IJs that are very high risk for sucking air into the vein. So always use Trendelenburg, especially for hypovolemic or euvolemic patients during high-line placement, and try to keep your ports closed and locked as much as possible. And same thing, using Trendelenburg or head of the bed down will keep your needle puncture below the heart. Then you can have the patient hum or bear down. You should never remove during inhalation where they could suck air into the vein. And hold pressure immediately as soon as the catheter emerges, because sometimes a fistula tract from the skin all the way to the vein is open when the catheter is initially removed. So be careful to compress that area immediately. If someone does develop air embolism, put them on high-flow nasal cannula will increase the rate of that absorption of that air. And placing them on their left side with the head of the bed lowered will get that air bubble to the apex of the heart and out of the right ventricular outflow tract so it doesn't shoot through the pulmonary circulature and cause a massive PE type physiology or hypoxic respiratory failure. Catheter-related bloodstream infections occur either during insertion or during maintenance of the central line, so always be sure to use maximum barrier protection, and don't hesitate to stop a procedure if you've contaminated yourself or your gloves and just re-gown. It'll take 30 seconds, and it's much better to take 30 seconds to regain sterility, then the extra 30 days the patient will be in the hospital for an MRSA, bacteremia, and endocarditis. One thing you can do is when following up catheter placement is always inspect your dressing daily. If the dressing is peeling up or if there's blood or other fluid building up under the dressing, ask the nurse to change it in a sterile fashion. The nurses have been trained to use sterile gloves, face mask, and hat, and a lot of chlorhexidine during changing. So if you see the sterile dressing getting contaminated or getting dirty, alert them ahead of time, because otherwise they'll just change it once a week. And the quicker you can remove a central line, the more likely you are to reduce catheter-related bloodstream infections. So after training and certification, we don't expect you to have a 90% success rate. After just 5 central lines in the jugular or 3 in the femoral, we don't expect you to be a pro. But we do expect you to be safe and know when to stop and when to ask for help. And don't forget, there's always intraosseous catheters at Santa Monica, Westwood, and the VA. We can give pressors while you're waiting for your fellow to come in at 2 a.m. to help you with the central line. You can get them emergent vascular access and get their medications in with an IO while you're waiting for definitive access. And be sure to log your central venous catheter removals as well. We do want you to have supervision there to make sure you're not causing the patient to be at risk for air embolism during that time. And because the dilation of the HD catheters and introducer sheaths are problematic, we do want you to do a few extra of those prior to being signed off as well. Though the HD catheter placements certainly do count for this jugular venous cannulation as well. They can count for both. And don't forget, you do need an attending to verify your competency with jugular venous cannulation. Finally, it's not just a minimum number of procedures needed for certification, but at least one of your supervisors must rate you as competent or proficient, and you yourself must also feel that you're in that range as well. Be sure to log all your procedures, even the failed ones. We want to hear about the ones that didn't go well and want to know how we can improve our education to help you out. And even after you're signed off, continue logging so we can track success and complication rates moving forward. So in summary, you'll be successful if prior to the procedure you ask yourself, what is the chance I'm going to be successful? And what is the chance that I cause complications? And if it's going to be difficult and risky, ask for help. And maybe don't spend as much time digging and mucking around and abort the procedure sooner rather than later if you think you're more likely to cause harm than good. Pick an easier target that's larger and more superficial will really increase your success rate. And always rule out DVTs. This is commonly forgotten that people don't compress the full length of the vein from the top of the neck all the way to the clavicle to make sure there's no DVTs occluding their path. And stay away from the clavicle when you do decide to insert the needle at least 2 to 3 centimeters above that site. Really practice using ultrasound to follow your needle tip. And this skill takes time to learn, so while you're trying to figure out where your needle tip is, always look down at the patient occasionally and ask yourself, how deep is my needle and should I have hit the vein by now? Again, a 1.5 centimeter deep jugular vein, if you insert your 6 centimeter needle 3 centimeters halfway in and you haven't hit the vein, you're too deep, you need to pull back and figure out where you are. You'll be more successful with the wire if you can keep the needle as still as possible when removing the syringe and inserting the wire. And always ask yourself, if I'm having resistance or difficulty advancing the wire, how deep is the wire? And that will help you troubleshoot if it's the wire coming out of the needle or if you're hitting something more distally in the vascular itself. Always confirm venous puncture with the ultrasound prior to dilation. This is how you can prevent putting the catheter into the carotid artery. And if you're struggling with the dilator, take a pause with the dilator, re-inspect your skin nick to make sure you didn't leave an extra tag of skin there, adjust your grip and angle of the catheter, and then make sure to pull back on the wire and maintain constant tension on that wire as that dilator is advancing through. And if you stick to these, you're going to be very successful and continue to grow in your skills as you progress. All right, that's all I got for now. Thanks for listening.